Good morning, ladies and gentlemen. I am Professor Ashar Ahmed Mashood, and I will be talking about cheilitis in this talk. I am returning to my channel after a long period of time because of my personal commitments. And I would like to request you that if you are hearing my voice, please subscribe to my channel. So let's proceed in today's lecture. Before I discuss about cheilitis, let's revise the few significant anatomical landmarks about the lips. So the lips have a vermilion border, which is the border of the lips, the oral commissures, which are the folds between the upper and lower lip. The upper portion of the lip is called as the sorry the cutaneous portion of the lip is called as the vermilion, while the cutaneous lips are that portion which is the skin portion covering the lip. The wet line is the line or the demarcation between the dry portion of the lips outside and the wet portion of the lips inside. Cheilitis. Cheilitis is a term that is used for inflammation of the lips that could be acute or chronic. The inflammation primarily arises in the vermilion zone but may extend to the surrounding skin and less commonly to the oral mucosa. So, generally, it starts at the vermilion border and it extends to the surrounding skin and it may enter into the mucosa. It may be caused by multitude of factors that include contact irritants or allergens, chronic sun exposure, and nutritional deficiencies, as well as many cutaneous and systemic illness. So, in this talk, we are going to discuss about different causes of cheilitis. So, this is a diagrammatic representation of a few common types of cheilitis, that is the actinic cheilitis, mainly affecting the lower lip, the angular cheilitis, which primarily is due to the nutritional deficiency, then granulomatous cheilitis, in which there is swelling of the lips, then exfoliative cheilitis, it is mainly iatrogenic or it is psychological, then eczematous cheilitis due to several contact allergens. So first, actinic cheilitis or solar chelosis. The actinic cheilitis is a pre-malignant disorder of the lip that is caused by chronic sun exposure. So it is seen mainly at the lower lip of patients in their fifth to eighth decade of life because it is a chronic sun damage. The frequency is higher in geographical areas with high UV radiation and open air workers and people with fair skin. Predisposing factors. The main factor is, of course, the UV radiation. The vermilion of the lower lip is particularly receive a high dose of UV irradiation and is poorly protected by keratin and melanocytes. So this is the common site of involvement. Tobacco smoking may aggravate the condition. Voriconazole therapy is further at risk because it also tends to dry the lips. Welding can cause a similar damage. So those persons who are involved in this profession are particularly at risk. It may be an early manifestation of genetic susceptibility to light damage like in xeroderma pigmentosa or oculocutaneous albinism. Immune defects include immunosuppression in organ transplant recipient, also predisposed to actinic damage and malignant transformations. Pathology. The histology shows acanthosis, there is thickening of the epidermis, hyperkeratosis, thickening of stratum corneum, and inflammatory infiltrate with plasma cells. The collagen generally shows elastotic degeneration. There can be nuclear atypia and abnormal mitosis in long-standing cases, and it may later on develop into invasive squamous cell carcinomas. Clinical features. The actinic cheilitis tend to affect the lower lip with sparing of the oral commissures. So this is the typical hallmark of this presentation. In early stages, there may be redness or edema, but after repeated UV exposures, the chronic changes sets in, which are dryness, scaling, and lip atrophy. Lip become thickened with small grayish-white plaques. Vermilion border become indistinct because of persistent inflammation, and eventually warty nodules form that may evolve into SCC. The suspicious features that should doubt you that the disease has entered into malignant transformation is pain, chronic ulceration, generalized atrophy with focal white thickening, persistent flaking and crusting. The estimated incidence of malignant transformation in actinic cheilitis is 3%, which is not a low percentage. So you can see the gradual evolution of actinic cheilitis, finally leading to atrophy. So here you can see these ulcers and cracking and white plaques, all the features are seen. A biopsy should be taken from an area representative of the lesional severity, as well from the areas with atrophy, ulceration, or induration. The other differentials would include discoid lupus erythematosus, lichen planus, leukoplakia. Management. Treatment of actinic cheilitis required to relieve symptoms and to prevent development of SCC. So the first is protection from the sunlight and further damage. Wearing broad-brimmed hats, using broad-spectrum sunscreens, which are applied generously and frequently. Ablative CO2 laser or photodynamic therapy with aminolevulonic acid may also help. Then if there are some malignant transformation, 5-fluorouracil twice daily for 2 to 4 weeks, or imiquimod 5% cream may be applied 3 times per week for 4 to 6 weeks. 50% TCA or 3% diclofenac gel may also be effective. For patients with severe actinic cheilitis with evidence of high-grade dysplasia, vermilionectomy followed by defect repair by primary closure. Laser ablation is an option for severe actinic cheilitis without evidence of high degree of dysplasia. Photodynamic therapy with or without imiquimod is also a treatment option. Following treatment, regular use of sunscreen lip salve containing para-aminobenzoic acid gives the best protection. Now, the second condition is actinic prurigo involving the lips. It is also a photodermatitis and is considered to be a variation of polymorphic light eruption. Onset is in childhood and spontaneously improve in adolescent but can persist in adult life. A family history is present in 50% of the patients. The condition predominantly affects women. The absence of mucosal involvement is distinguishing feature between Asian and white populations. The diagnosis of actinic prurigo is often based on clinical findings. Histology is non-specific and it shows acanthosis, mild spongiosis, edema in lamina propria, moderate to dense, band-like, lymphocytic, inflammatory infiltrate with eosinophils, and sometimes lymphoid follicles. There is a specific locus of HLA-DRB1 0407 gene identified in 60 to 70% of patients. And the lesions are induced by exposure of both ultraviolet A and B radiations. Clinical features. The facial skin and lips are involved in 2/3 of cases with an intensely itchy, excoriated papillar nodular skin eruption and lip pruritus, edema, scale, fissures, crust, and ulceration. So the hallmark is itchy papillar lesions. Polymorphic light eruption is present in actinic prurigo in American Indians. It is commonly present in young women with photosensitive facial rash, with pruritic lower lip cheilitis, and is associated with conjunctivitis, pseudotrigium, and eyebrow alopecia. Commonly, lesions are symmetrically distributed. So this is a feature of actinic prurigo. On biopsy, actinic prurigo is distinguished from actinic cheilitis, which is, of course, due to prolonged exposure of UV radiation in outdoor workers. And there is absence of epidermal dysplasia and solar elastosis in actinic prurigo. Serum IgE levels are elevated in nearly 50% of patients associated with moderate or severe disease. Management. The actinic prurigo treatment is with sunscreens, beta-carotene, and antihistamines. Topical corticosteroids can offer some relief. Topical application of tacrolimus may be effective in patients with milder disease. Phototherapy with Sorrelin plus UVA is an option. Then thalidomide is successful in patients with resistant disease. Pentoxifylline, cyclosporin, and azathioprine are other options in resistant cases. Angular cheilitis. Angular cheilitis is a chronic inflammatory lesion affecting the oral commissures. Usually, both oral commissures are involved. Most cases are seen in patients with denture-related stomatitis and is related to candidiasis. It occurs mostly in adult patients, particularly the older age group, and both male and females are involved. Most cases are due to the mechanical or infective causes or dry mouth, but nutritional or immune defects are also important causes. The infective agents has to be excluded. Immune deficiency such as diabetes and HIV should also be excluded. Outbreaks of acute pustular and fissure cheilitis may occur in children, particularly if they are malnourished, and in some cases, streptococci and staphylococci are the causative agents, in addition to candidiasis. Mechanical factors in edentalous patients who do not wear dentures or those who have inadequate dentures is a normal consequence of aging process which produce deep oblique curve and folds, and hence this area remains constantly macerated. The nutritional deficiency that contribute to angular cheilitis are deficiencies of riboflavin, folate, iron, and general protein malnutrition that also produce smooth, shiny red lips with associated angular stomatitis. And a combination of smooth, shiny red lips and angular cheilitis is also known as the chelosis. The disorders where lip anatomical relationships are changed, such as when vertical dimensions or occlusion is reduced, where lips are enlarged, such as orofacial granulomatous, Crohn's disease, or Down syndrome, may also result in angular cheilitis. So, any condition in which lips are swollen may also cause this condition. Hyposalivation, such as drug therapy, irradiation, or Sjogren's syndrome, is also a predisposing factor. Agents causing hyposalivation, including chemotherapy and anticholinergic drugs. And candidiasis and staphylococci are the common causative agents. Clinical features. The most common complaint is soreness, erythema, and fissuring affecting the angle of mouth. Typically, condition is persistent or recurrent. Atrophy, erythema, ulceration, crusting, and scaling may be seen. Lesion occasionally extend beyond the vermilion border into the skin in form of linear furrows or fissures radiating from angle of mouth, which are called as the ragates. So these are the fissures which are angulated from the corner of the mouth. Eczematous dermatitis may extend into cheek or chin. Management. Management of angular cheilitis is sometimes difficult and therapy need to be prolonged. First of all, look for the dentures in old patients and at night and stored in the denture should be stored in the anti-candidal solutions such as hypochlorite. Denture-related stomatitis should be treated with antifungals and miconazole is a commonly used cream. Skin lesions should be swabbed and staphylococcus infection, if found, should be treated with fusidic acid ointment or cream or maybe with oral antibiotics. So miconazole plus hydrocortisone, fusidin plus hydrocortisone cream, clotrimazole plus hydrocortisone and nystatin plus hydrocortisone are the other choices for limited and early condition. Chapping of the lips. Chapping is a reaction to adverse environmental conditions and caused by freezing cold exposure or hot, dry winds. Keratin of vermilion loses its plasticity so that lips become sore, cracked, and scaly. Affected person tends to lick the lip or to prick the scale, which aggravate the condition. And the treatment is definitely by application of petroleum jelly or using good quality lip slaves. This is the chapping. Lip lick cheilitis. Lip lick cheilitis, also known as the lip licker dermatitis, is a condition that occurs commonly in children and young adults, and when someone chronically licks their lips, damaging the skin with saliva. And it is characterized by dryness and scaling and redness, inflammation around the lips, a small crack and fissures, and itching and pain. The lip lick cheilitis is common in children and in cold, dry weather, and it is treated by first convincing the children to avoid lip licking, apply lip balm with ceramides, petrolatum, and shea butter, drinking lots of water, using humidifiers, protecting lips from the harsh weather, and using a prescription topical steroid ointments for the oral dermatitis. Contact cheilitis. Contact cheilitis is an inflammatory reaction provoked by irritants or sensitizing compounds leading to type 4 hypersensitivity or allergic contact cheilitis. Substance leading to allergic contact cheilitis include medicaments, cosmetics, particularly in the lipsticks, toothpastes, mouthwashes, and may include other items like mouthpiece of a musical instrument. Allergen groups include drugs, vehicles, perfumes, flavorings, dental materials, and photo contact products such as sunscreens. Some of the specific allergens are described below. Medicaments include topical anesthetics, corticosteroids, antimicrobials, antiviral, antibacterial, anti-steroid therapies, plus their vehicles, that is lanolin and propylene glycol. So all of these can cause contact allergy on the lips. Cosmetics include lip balms and lipsticks. Components include fragrances and flavorings, limonene, linalool, cinnamon, essential oil, preservatives, vehicle allergens such as lanolin and propylene glycol. These are some examples of allergic eczema on the lips. Toothpastes like mint, spearmint, or limonene, lanolol, carvone, surfactants, tin, and other metals. Mouthwashes like chlorhexidine and triclosan. Dental materials may also cause this problem. So lipstick cheilitis is sometimes confined to vermilion, but more often extend beyond. It may be persistent irritation and scaling, or more acute reaction with edema and vesiculation. Hyperpigmentation is occasional complication, and management is avoidance of contact allergens and application of topical corticosteroids like fluticasone, propionate, mometasone, furoate, and tacrolimus. Drug-induced cheilitis. So there are many drugs which cause cheilitis, which include hemorrhagic crusting of lips, which are a feature of Stevens-Johnson syndrome. Aromatic retinoids such as acitretin and isotretinoin frequently cause cheilitis, dryness, and cracking of the lips. And similar effects are also seen with voriconazole. Other causes include protease inhibitors, vitamin A's, atorvastatin, busulfan, clofazimine, clomipramine, methyl-dopa, psoralen, sulfasalazine, tetracycline, streptomycin. Eczematous cheilitis. It's a little different from allergic contact cheilitis as lips are secondarily involved in atopic eczema. Treatment is with emollients and topical corticosteroids and sometimes potent steroid like fludrocortisone may be required. Exfoliative cheilitis is uncommon inflammatory condition affecting the vermilion border of one or both lip that results in peeling, cracking, pain or burning and is a significant cause of morbidity. The precise cause is unknown but is frequently associated with atopy or seborrheic eczema and therefore considered as a localized form of eczema. However, underlying mental health problems ranging from stress and anxiety to combined anxiety and depression or obsessive compulsive disorder and eating disorder may also contribute. Secondary infection is also frequent. Patients present in adolescent and early adult life. Male and females are both affected but more commonly seen in female. The process starts in middle of the lower lip and spread to involve the whole of the lower or both lips. It is more or less confined to vermilion or vermilion border and persists for months or years. You will find patients themselves picking and peeling off the dry skin and applying copious amount of emollients. Patient complain of pain, burning and discomfort. There is a large psychological morbidity. Patients start to avoid wetting of their lips in shower and guard their lips, trying to have as little contact with liquid and food as possible. Some drink through straw and allow large amount of keratin to sit on the lip surface, which is the cause of this condition. While investigating swab from the nose and mouth for microscopic culture and sensitivity are vital, biopsy is not indicated. Patch test is sometimes valuable. Management. Some cases resolve spontaneously and with improved oral hygiene. Modification of unhelpful habits like lip licking is important. Vaseline or lip balm should be limited to occasional use. Wiping away the loose keratin each morning after shower is important. Twice daily application of tacrolimus 0.1% for 6 weeks and exposure to direct sunlight must be avoided. Antiseptic mouthwash should be used. Finally, and most important, psychological assessment is recommended in those with mental health problem and should be addressed. Foreign body cheilitis or fillers complication. Nowadays, since lots of patients are getting fillers for their lip, the injectable fillers comprising of hyaluronic acid is the most frequently cause of foreign body cheilitis. Although the good quality HA fillers have low side effect profile and are dissolvable, and they are temporary and do not last more than 6 months. Synthetic injectable materials that are permanent is now rarely used and which were associated with high risk of complications. So if a filler is injected, it may result in edema, erythema, paresthesia, pain, bruising, or hematoma, which are usually subsides in a few days' time. Late complications include lumps caused by volume effect and poor injection or poor quality of filler used, infection and foreign body reaction. The more serious complications are delayed onset nodules or vascular occlusion resulting in tissue necrosis, but the causes is by poor placement of filler, poor technique, and untrained injectors. You can see in this picture there are few nodules on the lips with hematoma and bruising. So different fillers are used. The most commonly used fillers for lips are hyaluronic acid filler. Nobody use fat nowadays. And there is no use of PLLA or silicone or other kind of fillers nowadays for the lips. And if anybody is using them, then these fillers are bound to cause complications. If you would biopsy a nodule induced by filler, there will be a foreign body granuloma with multinucleated giant cell. Usually, the nodules formed by fillers, by hyaluronic acid fillers, are dissolved by hyaluronidase, and antibiotic is given for infection. For foreign body granuloma, intralesional corticosteroids is given to break up the clumps of the material, or otherwise surgical intervention is done. Glandular cheilitis is a peculiar kind of cheilitis caused by inflammatory changes and swelling of salivary glands of the lips. Clinical diagnosis is based on the clinical findings of swollen lip with dilated salivary gland ostia, as you can see in this picture, extruding a mucous material. Several factors appear to play a role, like atopy, infection, and tobacco use. When swelling is persistent and fluctuating and with acute or chronic course, investigation for underlying cause may be helpful. Infective cheilitis. There are several causes of infective cheilitis, like viral infections like herpes simplex virus, varicella zoster virus, human papilloma virus, and orphan vaccinia. Bacterial causes include the dental infection, fruncle, carbuncle, staph, streptococcus. Impetigo may mimic herpes labialis, chancrum aureus by fusospirochetal infection. Then syphilitic lips are common cause of extragenital primary syphilitic chancre. Most lip chancres occur in male and tend to occur in upper lip and female in lower lip. In secondary lip, moist, flat papillonodular lesions, which are condyloma latas, often appear at mucocutaneous junctions. So here impetigo is seen in this picture. There are several granulomatous infections involving the lips that include tuberculosis and leprosy and rhinosteroma. These appear as plaques or nodules, and lip appear to fuse to alveolar processes. The most common protozoal infection is leishmaniasis, mucocutaneous leishmaniasis. Sometimes cutaneous leishmaniasis may have the mucosal findings. Swelling of the upper lip and later enlargement and destruction of the lip, reflecting the three stages of edema, granulomatous proliferation, and necrosis. The fungal infections mimic the granulomatous inflammation, and commonly infections are blastomycosis and paracoccidomycosis. Other causes include Kawasaki disease, which produce red swollen lips with fissuring and exfoliation. Plasma cell cheilitis is idiopathic inflammatory condition present with well-defined induration, erosion, erythema, and dense plasma cell infiltrate in the lips on histology. This plasma cell cheilitis is the counterpart of Zune plasma cell balanitis. Present as circumscribed, flat or elevated patches, and lower lip is commonly involved in elderly persons. Histology demonstrate dense band-like lichenoid infiltrate predominantly comprising of plasma cells. The cause is unknown, treatment is difficult. It responds to application of powerful topical corticosteroid like clobetasol or intradermal injection of triamcinolone or topical tacrolimus. Similar lesions tend to form a tumorous mass with hyperkeratotic surface that needs to be differentiated from extramedullary plasmacytoma, which is also called as the plasma acanthoma. So this brings me to end of this talk. I hope this brief talk was helpful for you in understanding different type of cheilitis. So join me next time with another edition of my lecture. Thank you very much for your attention and goodbye and have a very good day.